Okay. This is the last online session from me to you, and it's about instruments. Instruments is a fixed station of the OSCE examination, and it is important because it is a practical. You examined about one instrument and medication also. The medication, we will not take a session about it because we say all the vital medications, all the life-saving medications, including the IV fluid, involved in the examination. You should know. You will not ask about antibiotics and about dose of antibiotics, about indication of antibiotics, but the life-saving and the vital medication, especially used in emergency situations, in an emergency department, you should know, and you will be examined about one of them. Instruments is also important because most of these instruments are used in emergency situations. I think most of you know most of the information about the instrument from the clinical sessions, from the practical life, from other courses. Now we will talk about something specific to pediatrics. And we will start with the first instrument used in a pediatric field. Of course, what is this?
O2 mask.
Oxygen mask.
This is oxygen mask, or what's called O2 face mask. What do you know about this face mask? What is the flow rate of the face mask? What is the oxygen level that gain from it?
الفلو ريت من 5 إلى 10 والساتوريشن مالته أو التركيز مالته ل50 يعني 51 أو 60.
What about the side effects, or what about the adverse effects of use of face mask?
Interfere with feeding.
Yes, very good. Now the flow rate of O2 face mask is about 5 to 10 liters per minute, and this is regarded an accepted or an high level of flow rate. The pressure that given by face mask may reach up to 60%. But of course, the use of the face mask is for the oxygen therapy in cases of respiratory distress, in cases of decreased the O2 saturation, and of course, we can give the nebulization, including the ventral nebulization, the adrenal or racemic epinephrine nebulization can be given through the face mask. The adverse effect of it interferes with the feeding, and it is especially tightly fitted in the face, so it is poorly accepted by infant and toddlers. They try to remove it. We have another source of liberation of O2 to patients with respiratory distress, which is the nasal cannula. The nasal cannula, unlike the expectation, it gives a flow rate and a pressure less than the face mask. So the flow rate is not more than 6 and the pressure is not more than 40%. But the advantage of using nasal cannula, it leaves the mouth free for nutritional purposes and for communication. So this is something superior to the using of face masks, especially in the pediatric age group. But the high flow, because in face mask, there's a space between the O2 source and the airways, or the mouth and the nose of the patient. But in nasal cannula, the flow comes directly inside the airway, so it will lead high flow relatively. This may cause gastric distension because some of them go to the stomach, and may induce vomiting, and there is a chance of aspiration or nasal mucosal injury because putting the nasal, this is called the nasal process, that enter inside the nosotrols. So if it persists or stay for a long time, it may cause mucosal injury. And it may cause irritation to the mucosa, and even may cause a mucosal edema or induce the nasal secretions. Now we will go to other instrument, which is commonly used in the neonatology and even in pediatrics and medicine and in general, because this is a life-saving, which is called the ambu bag. What are the abbreviations of ambu bag? Ambu bag, it is artificial manual breathing units. The scientific name for this device is, or this instrument is bag. Here is the bag, valve, and mask. So they call it BVM. And also we have another name, which is a self-inflating bag, because when we deflate it, it will re-inflate spontaneously. Unlike the ambu bag that's used in the anesthesia, which is another type of that is need to be re-inflated. But here is a self-inflating. علي حسن صعب، ايش موعد السجن؟ علي حسن سيشن بثنتين وربع. Again, it is also called manual resuscitator because it is used in the resuscitation of babies, of patients in general. They may have apnea or difficulty breathing. Now, this is the parts of the ambu bag, or the, as we say, the bag, valve, and mask. Here is the mask, which is always, it is clear or transparent to make a view for the color of the tongue and or the mouth of the patient. And it is comfortable. This is a cushion for to make it comfortable when fitting on the mouth and nose of the patient. Here is the valve system, and the valve system is very important to prevent the breathing or the air comes in the expiration from going back to the bag. And here is the bag, which is a recoil and has the feature of self-inflation. Sometimes the bag is related or is connected to a tube reaching to auto source. And if you remember from the session of neonatal resuscitation, we say it may be connected to auto source, especially in the resuscitation of preterm newborns. And it is maybe connected to oxygen reservoir bag, like this. Another picture to show the valve system. This is that we have two valves. So the valve is open during the deflation of the bag, making the O2 coming inside. Then it close during expiration to prevent the CO2 from coming inside the bag. So in this way, we just yield or we just liberate O2 for the patient, not the rebreathing of the exhaled CO2. And here is what is called the pressure limiting valve, because this will control the pressure yielded by the deflation of the bag, because sometimes it may be traumatic to the patient. This is the auto-inlet again, and this is the reservoir of bag contain auto in some cases. Another slide to explain the parts of ambo bag. This is the face mask, and this is the cushion to make it comfortable for the face. And this is the expiratory valve. We say it will open during deflation, and it will close during inflation or during expiration of the patient to prevent the CO2 coming inside the bag again. And this is the valve that is control the pressure of control the pressure coming from the inflating bag. And this is the other parts. Now we have different volumes or different sizes of the bag that is used for neonates, for children, and for adults. And it also may comes with different shapes, but the same principle of action for all types. The face mask is triangular, is rounded, it is the same. The ambo bag changing in its color, but it is the same regarding the valve system and regarding the volume of the bag. So we have the neonatal ambo bag that is a volume of 250 ml, and we have the pediatrics, which is about 500 ml, and we have the adults that's about 1,600 ml. All these found in this slide, and also here starting from the neonatal size reaching to the adult size. Now, what are the indications of using of ambo bag? Firstly, is for resuscitation, because we call it the manual resuscitator. We use it for mechanical ventilation. Patient put on mechanical ventilation. Firstly, after intubation, they use the ambo bag until the patient is fit to be connected to the ventilator. So this is used in these situations. Cases of apnea, we use, because this is yield a positive pressure ventilation. You remember that from the session of neonatal resuscitation, when there is no breathing, we use it to yield a high, we call it the positive pressure ventilation, and may enhance or may initiate the breathing. For intermittent positive pressure ventilation, which is a source or sort of ventilation, we have the continuous positive pressure and we have the intermittent. So here is used for the intermittent positive pressure ventilation, and we use it for the upper airway obstruction or severe stenosis that happened due to a foreign body inhalation, or due to, as example, if there is edema, laryngeal edema, and maybe due to hypersensitivity or allergy to something, or it may be due to infectious causes, and viral causes like or bacterial like in epiglottitis or in severe croup. And hypercapnic respiratory failure. Hypercapnic, which is called, what we call the hypercapnic respiratory failure. How many types of respiratory failure we have? What is very good. So we have two types. So both types, the type 1 and type 2, we can use the positive pressure ventilation in it. So if I ask you, what is the type of respiratory failure that it happened in birth asphyxia? It is type 1 or type 2? Birth asphyxia.
Type 2.
Very good. Type 2, because in birth asphyxia or in there is a hypoxia and hypercapnia. That's why the patient has mixed acidemia. The acidemia comes from the metabolic lactic acidosis and comes from the respiratory acidosis because of the high level of CO2. So it is a type 2 or hypercapnic respiratory failure. Patient altered mental status with inability to protect the airway. There is no problem, mechanical problem in the ventilation system of this patient, but because a low level of consciousness, he may not maintain the spontaneous movement, or he not maintain the movement of the air or O2 through the airway. So here the use of the umbo bag is useful. Or patients who are undergoing anesthesia for elective surgical procedure may require the BVM ventilation, but this is, of course, the other type of umbo bag, which is need a re-inflation, not like the self-inflation that used in the emergency situations. Now, what are the contraindications of using a BV mask? If there is a total upper airway obstruction, not a stenosis, not a narrowing, but there is a total upper airway obstruction. So here is no rule for using the positive pressure ventilation. The first thing here is to open the airway to make sure that the airway will be patent. And here, and if it is not available, of course, here is the rule of intubation. Increased risk of aspiration after paralysis and induction of anesthesia. Of course, if when you use positive pressure ventilation and fill the stomach with food, as example, with feeding, you know, you give the O2 to the airway, and it will be passed also to the stomach. So gastric distension, and it is filled with feeding, it may lead to increased risk of aspiration in these cases. These are the contraindications. Now we talk about the complication of using a BV mask. Hypoventilation or hyperventilation. This is according to the use. This is a mechanical error or mechanical problem happened in using. It may yield less than O2, or it may yield more than O2, causing hyperoxia. So this is related to how we use the umbo bag. As we said, the inflated air in the stomach causing gastric insufflation, and it may lead to aspiration. Lung injury from overstretching. We have two trauma that can happen to the lung from use of the umbo bag. Either overstretching of the umbo bag leading to volume trauma related to the volume, or it may be from the overpressurizations. This is related to the pressure yielded by the umbo bag, called barotrauma. So either volume or barotrauma or both. And this is especially seen in preterm babies because they have fragile airways and may be ruptured, and pneumothorax will be the result of barotrauma or volume. Both of them could lead to injury in form of mainly pneumothorax. Lung aspiration, and we talk about why lung aspiration happened, because of the gastric distension or full stomach. Air embolism, yes, sometimes air embolism may be come inside the circulation because of the high pressure and causing air embolism, and we know the dangers of the air embolism. Now we will go to other instrument, and I think it's clear to you this is a laryngeal laryngoscope. And you can see here the difference between these laryngoscopes. This is a curved one, and this is a straight one. Of course, the parts of the laryngoscope, this is called the blade, and this is the light source, and this is the rod or the containing the battery, and use it in fixation of the or introducing the laryngoscope. So this is called, the full term is a direct rigid laryngoscope. Direct because it is go directly to the larynx, not like the indirect by using the mirror that is used by the otolaryngologist. And rigid because it is rigid. This is a metal, not fiber. And laryngoscope because this is laryngoscope to go inside the larynx or make an inlet to the larynx. Now, we say we have two types of blades. We have the curve that's called the Macintosh, and we have the Miller blade, which is the straight. This is, as we say, the disposable handle contains the battery for using of the laryngoscope. This is another slide showing the straight blade, or what's called the Miller. And the Miller causing depressing of the tongue. So this is preferred in the infants, and we use it in a newborn, the Miller type. While the curved blade, it pushed the epiglottis to one side to visualize the glottis, and this is preferred in children more than 8 years. Now, you can see here there is a different sizes of the blades and even the handles for both types, used starting from the neonatal period up to using to the adult size. What are the indications of using the laryngoscope? Of course, for intubation. We can do intubation and endotracheal intubation without using laryngoscope, and intubation for general anesthesia. Foreign body removal also can be done by laryngoscope. Biopsy for a growth on vocal cord or hypopharynx, and the treatment of benign and malignant diseases. And it also used in diagnostic uses in cases of stridor, hoarseness of the voice, suspicion of malignancy, or choking episodes. Some of these, some of these indications are surgical, not related to us, but we use the laryngoscope as a neonatologist or pediatrician in neonatal resuscitation, and even in the neonatal and the pediatric intensive care unit. We put the endotracheal tube for the patients to connect them to ventilators. So this is our job to make the intubation by using the laryngoscope. Now, also minor damages of soft tissue. These are the complications. It is the minor damage of soft tissue, of course, because of using the direct or the metallic, and it may lead to tooth damage also during introducing it, or severe injury to the larynx causing permanent scarring or even ulceration and abscess. This slide shows the size, the appropriate size selection of the laryngoscope according to the age of the baby. So in a newborn, whether term or preterm, we use the Miller. We say the Miller up to 8 years of age. So it's called Miller 0. And always it should be available at the time of doing resuscitation for babies. And there is a different sizes, larger sizes, of course. Here from the age of 6 to 12 years and beyond, we use the Macintosh, actually from the 8 years and beyond. and then it will be like the laryngoscope used in adults.
دكتور بالنسبة مطلوب يعني مطلوبات معنا نحفظها؟
لا just to know, just to know. Now we go to other instrument that is also commonly used in pediatric emergency situations, or in unit, not commonly used in neonatal resuscitation. We say it's of a low percentage. Very rarely we need to reach the level of using the endotracheal intubation. So this is endotracheal tube. And can you see here, we have two types of the endotracheal tube. This is called the cuff size, and this is the cuff, and this is the uncuffed size. We will know what is the difference between two types. This is, of course, the uncuffed endotracheal tube. And this is the cuff. Of course, the cuff should be inflated, like what happened in the Foley's catheter, as example, when we giving distilled water of 5 or 10 ml to inflate the Foley's catheter to make a fixation port inside the bladder. So, what are the parts of the cuff size? You can see here, this is the connector that's connected to the endotracheal tube, the ventilator, or to the ambo bag. And this is called the bevel, which is inserted inside the trachea. And this is the balloon inflated to make the cuff inflated, and we say there is indication for use the cuffed size, or there is age limitation. So the uncuffed vs the cuffed tube, what are the differences? You can see here the differences between both. So the larger internal diameter is with uncuffed. It is of larger diameter, and it is of low resistance to airflow, and it avoids the trauma to the subglottic region, and always allows very easy suctioning. While the cuffed endotracheal tube, it is prevent the inhalational agents. So if we want to make intubation for patients with poisoning of inhalational agents, it's better to use or it should use the cuffed endotracheal tube, like in patient with kerosene poisoning or hydrocarbon poisoning, because this is volatile inhalational agent. It may cause inhalation and aspiration. So here reduce the risk of aspiration if we use the endotracheal cuffed type. And it is also avoid the multiple laryngoscopy and intubation, and it is improve the ventilation and what's called the end-tidal carbon dioxide monitoring. These are the differences between both types. The using of the internal diameter or the inner diameter is according either to the weight or according to the age group. So what we use in term babies here is different from that with term babies. Or it is maybe the same. It is the smallest size between 2.5 to 3. Then it will increase until reaching to the adult male or adult female size. Now we have an equation to know the appropriate size of cuffed or uncuffed tube if we didn't know these tables of the size, which is the age of the patient over 4 plus 3.5, or the age over 4 plus 4. We can know the appropriate size of, or we can detect the appropriate size of using both a newborn. But as of the tube, but as I said, for the newborn, it is a 3 to 3.5, and the cuffed tube, it is also classically used in age above 5 years. Or at least it cannot be used in patients less than 1 year. We can't use the cuffed tube side. So what are the indications of the endotracheal tube? Of course, we will say general anesthesia. Congenital malformations and diseases of the upper airways. Relief of airway obstruction. Cases of epiglottitis, facial burn, smoke inhalation, vocal cord edema, to make the patency of the airway. And mechanical ventilation, patient need to be connected to ventilator. Of course, you should intubate him. Neonatal resuscitation, you know, from which point the endotracheal intubation is considered, you should know it. And various forms of acute respiratory distress, whatever the cause. The patient, when has a severe acute respiratory distress, and he cannot maintain the normal saturation or the normal breathing, he may use or he may be in need for the intubation. Of course, in cases of cardiac and respiratory arrest, and of course, if there is complete airway obstruction, shortly we say that there is no role for the ambo bag in complete airway obstruction. The role is for the intubation. And of course, inability of the conscious patient to breathe adequately. Patient conscious, but there is problems with maintaining the breathing adequately, or inability of unconscious patient to protect his airways. Unconscious patient, and especially if the Glasgow Coma Scale is below than 8, there is no guarantee the patient can protect his airways. There may be obstruction because of secretions, as example. So in those patients, the decision is to intubate them. Or conscious patient, but cannot breathe adequately. Like here in the critical cases of COVID-19, when the saturation become low and there is signs of acute respiratory distress, and there is a severe hypoxia, and there is a signs of impending respiratory failure. So it's better, or the decision is to make to do mechanical ventilation, of course, and firstly you have to intubate the patients. But of course, for everything there is indications, there is contraindications. So what are the contraindications for the intubation? If there is severe airway trauma or obstruction that doesn't permit the safe placement of endotracheal tube. لا شو نسوي بهاي الحالة؟
Tracheostomy نسوي دكتور؟
Very good. Tracheostomy. If there is something handle or prevent the intubation or even the laryngoscope use, we should do tracheostomy to overpass this problem. Emergent tracheostomy is the choice. Here. Complications. We have complications during intubation, during the process of intubation, and we have complications during the state or during the course of intubation. And we have complications during the extubation. We will know it accordingly. During introduction of the tube or admission of the tube, we may cause trauma to the lip, to the tongue, or we may cause tooth avulsion. And of course, soft tissue injury in form of oropharyngeal laceration or hematoma or laceration of the vocal cord or even to the trachea. This is a mechanical or technique error. Hypertension and tachycardia or arrhythmia. This is a system reflection or complication causing the abnormalities in the rate and the rhythm, or even causing increased blood pressure. Pulmonary aspiration, especially when there is full stomach, laryngospasm and bronchospasm as a reflection to putting the endotracheal tube inside. This is, of course, may happen. There may be spasm, this is a muscular wall. And we may do esophageal intubation wrongly. And this is one of the mechanical errors that happened during the neonatal resuscitation and making the resuscitation failed when the endotracheal tube goes inside the esophagus and all to going to the stomach. During remained intubation, now there is no complication during introduction of or putting the tube. While the patient, he is intubated. What is the complications, or what are the complications may happen? Obstruction. Obstruction comes from a clinking of the tube, or there is secretion, more of secretion, mucus secretion, sputum forming, or overinflation of the cuff. In cuff type, if there is overinflation, may cause upper airway obstruction, not upper airway obstruction at the level of the trachea, I mean. So this is making a problem. Accidental extubation. Sometimes this has happened in ICU. Sometimes the patient intubated and there is accidental extubation, or the tube come to inside one of the bronchi, to the right or to the left. Disconnection from a breathing circuit. Endotracheal tube really connected to the ventilator. So there may be disconnection. And of course, the patient will complain of the complications, hypoxia and even apnea, if there is no spontaneous breathing. Pulmonary aspiration again can happen, pulmonary aspiration. And during extubation, what can happen while we remove the tube? Laryngospasm as a reflex, right? Laryngospasm. It may cause even upper airway obstruction. So it's not easy always to do the extubation, especially if a long-term intubated patients. Pulmonary aspiration, edema of the upper airway, also a reflection to remove, and the edema may be so severe to causing upper airway obstruction. Now, and tracheal stenosis in prolonged intubation, or laryngeal granuloma. All these are complication of endotracheal tube after extubation or during intubation, and you have to answer accordingly. Now we go to other instrument, which is, as you see here, the disposable spinal needle. And of course, we know or we see the spinal needle and its main use in lumbar puncture. We have different sizes of spinal needle. Starting from that can be used like the cannula, like any instrument, starting from the size that can be used in a neonatal period, reaching to the adult. So, spinal needle, we have two dimensions or two values for the spinal needle, which is the gauge of the needle. It is between 20 to 21, and the length of the needle, which is about 1.5 inch in those less than 1 year. Then from 1 year to middle childhood, we can use the spinal needle of 2.5 inch. And for those older children and even adolescents, we can use the 3.5 inch size. Now, this slide showing the parts of the spinal needle. This is called the stylet, and this is the needle. So after introduction doing the lumbar puncture, removal of the stylet, and like the cannula, and then the needle will be inside the subarachnoid space, and the CSF fluid will come, or we introducing something through it. And we have two ends for the CSF needle. We have the standard needle, and we have the atraumatic. So here is the opening at the tip of the needle, and this is less traumatic, or called atraumatic. The opening is on the side. This is another slide showing the parts of the needle. This is, as I said, the stylet. Removal of it after inserting the needle, doing the puncture. And this is again showing the stylet and the needle itself. The needle will stay inside the subarachnoid, but the stylet, this is the containing the sharp end that is doing the puncture, through the skin, I mean. Now the indications of the spinal needle. We have diagnostic indications and we have therapeutic. Of course, doing lumbar puncture for diagnosis of infectious disease like meningitis or encephalitis. And inflammatory diseases like Guillain-Barré syndrome, or the correct pronunciation is Guillain-Barré. It's not Guillain-Barré. This is Iraqi pronunciation. It's Guillain-Barré. Demyelinating diseases like multiple sclerosis, acute demyelination polyneuropathy also. Oncologic disease like medulloblastoma. Metabolic disorders like the mitochondrial encephalopathy and gamma aminobutyric acid metabolism disorder, or GABA disorder. Spontaneous subarachnoid hemorrhage, and here the finding will be من اكو spontaneous subarachnoid hemorrhage ونسوي LP. شو راح نحصل؟ شو يصيحوا له الفايندينج؟ شو يسموها؟ لها اسم. شو راح يجينا اللمبر بانكشر؟ شو راح نحصل من عنده؟
كيف تجينا دكتور؟
Xanthochromia, called xanthochromia because it is bloody. We introduce the needle in the subarachnoid space, so because there is hemorrhage, it will be bloody CSF, called xanthochromia. Benign intracranial hypertension. That may be diagnostic and maybe therapeutic. Contrast dye for X-ray study, for example, myelography. Nowadays, the use for this indication decreased by using of the MRI. Myelography for the radiculopathy, previously by contrast study the diagnosis. Now the MRI is efficient and invasive to do the diagnosis, or to ensure the diagnosis. Therapeutic indications in anesthesia, of course, spinal anesthesia. In analgesia, sometimes we introduce or we insert analgesics through the CNS, through the spinal needle. Antibiotics can be used through it, like streptomycin, tobramycin, gentamicin, vancomycin. This is not used routinely. This is in meningitis developing after neurosurgery or placement of an external ventricular catheter that doesn't respond to IV antibiotics. So this is after failure of using IV antibiotics in meningitis as a complication of a neurosurgery or external ventricular catheter. What we mean by external ventricular catheter? In which cases used?
ممكن تعيد دكتور بلا زحمة؟
هسه فهمنا المننجايتس after neurosurgery، يعني مو المننجايتس العادية. Meningitis developing as a complication for neurosurgery. If there is failure to response or نستخدم intrathecal يصحوا له intrathecal antibiotics. لكن what is the meaning of placement of external ventricular catheter?
In hydrocephalus?
Very good. VP shunt in hydrocephalus. And there is no response to IV antibiotics, so here use the intrathecal, goes directly to the meninges. Chemotherapy, also used intrathecally. Idiopathic intracranial hypertension, we say it may be used for diagnosis and for treatment for relieving of the pressure. This is useful in those patients. Now, the contraindications. Not all patients we can perform LP for them. First is an increased intracranial pressure due to cerebral herniation or impending herniation or possible increased pressure with no focal neurologic signs. Coagulopathy, cases of thrombocytopenia and the platelet count is less than 50,000. There is a risk of spontaneous bleeding and causing hematoma at the spinal cord. And you know, hematoma inside the spinal cord, it may cause paralysis. So it is difficult to do it, contraindicated. Space occupying lesion, of course, is contraindicated. And نخاف من cerebral herniation. Infection near the puncture site. On the skin, there should no skin infection near the area. All the area should be sterilized. But if there is infection, we may introduce infection inside the CNS by doing the LP. Significant cardiopulmonary compromisation. Patients who are cardiopulmonary not stable, we can do LP for even whatever the cause or whatever the indication. And if there is vertebral deformities, of course, this will prevent the doing the LP correctly and getting the findings. Prior lumbar surgery, of course, this is a contraindication. Severe vertebral osteoarthrosis or osteoarthritis or degenerative disc disease also prevent us from doing the lumbar puncture. Now, we did the lumbar puncture and we may have complications, cerebral herniation, and we mentioned the cause is increased intracranial pressure. Cerebral herniation may cause apnea and sudden death. This is a very, very dangerous. Cardiopulmonary compromisation. The patient was stable, was eligible to do the LP, but after doing the LP, he may have cardiopulmonary compromisation because this is an invasive procedure needing leaning of the patient or making bending of his back. So during this posture, we may induce the cardiopulmonary compromisation. This is not our mistake, but the procedure itself may cause this complication. Some of the complications and the procedures may be due to mistake we did, but sometimes the procedure itself causing this complication. So this is one of the complications because of the procedure itself. Bleeding and hematoma. Bleeding and hematoma can be happened even if the patient has a normal level of platelets. Local pain, of course, it is painful. So that's why before or at the time of doing LP, the patient should be locally anesthetized. inserting the xylocaine at the area of the doing the LP, and given the time for action before doing it. And sometimes the patient may be sedated during doing the LP. But even after the absence of or removal of the effect of the local anesthesia, the pain will develop. Infection, of course, this is if infection develops, so it was a wrong maneuver or wrong technique in doing LP, because it should be done under completely sterilized conditions. We should sterilize the back of the patient, and we should be sure about the equipment we use. It is clean and sterilized, and of course disposable, so used for a single time to prevent the infection. Headache. The headache, it can happen in about 1/3 of the cases that doing LP, whatever the cause. CSF leakage. Presumptively, after doing the LP, after removal of the spinal needle, there is no CSF leaking through the skin, but sometimes there may be a leakage. Acquired epidermal spinal cord tumor, and this is caused by implantation of epidermal material into the spinal canal if no stylet is used in skin injury. So this is the importance of the stylet. Prevent the epidermal material اللي ناخذها من السكن ونحطها inside the spinal canal. If you use a stylet which is sharp, prevent this complication. Now we'll see how perform the LP. You know what is the level? It is a L3, L4, or L4, L5. Because you know the spinal cord at this level is ended. And what we have here is called the quina. And the LP should be inserted at a manner making it parallel to the vertebra, and the end is inside the subarachnoid space. Another slide showing the sitting position or the lateral decubitus position. In pediatrics, we can use both. In pediatrics, we can use both positions during doing the LP, and this is determined accordingly. ممكن نقول نسوي لها the sitting position or not, starting from the neonatal period. So we have the sitting or lateral decubitus, and how we detect the landmarks of reaching to the intervertebral space that we insert the LP inside it. It's by the level of the landmark is the level of the posterior superior iliac crest, which is at the level of L5. So the space, we can palpate the vertebral and the spine, the spine, and we can palpate, so above the level of the posterior superior iliac crest, this is the L4, L5. We can do it as in L3, L4, or L4, L5. So this is a lumbar puncture in sitting position for newborn. And this is again for a neonate with, شوفوا size. This is the stylet removed, the needle inside, and collecting the CSF sample. And this is lateral decubitus for the newborn. So both of can use. This is again showing how the needle is inserted parallel to the spines, and this is in the L4, L5 space, and inside the subarachnoid space. Again, this is showing in lateral decubitus for lumbar puncture. This is the inside subarachnoid space. So starting to collecting the CSF needle. And you can see here the sterilized and aseptic technique to collecting. How many tubes we should collect? The sample of CSF should be collected in more than one tube. How many tubes and why?
One for chemical studies.
Yes.
And one for white PC and studies.
Yes.
And third for culture.
Yes, three samples or 3 tubes, one for the biochemistry, one for the cytology, and one for the bacteriology. So what are the normal CSF parameters? This is in patients out of the neonatal period. The appearance, it should be clear colorless, just like water, just like distilled water. Blood cell, it may contain, or it should contain white blood cell less than 5, and all are lymphocytes. Presence of one neutrophil indicate abnormal, indicate infection, and ideally it should not contain any red blood cell. So that's why it is a clear colorless. This is the cytology. The glucose, it should be about or greater than 2/3 of the blood glucose. If it is lower than this, this is pathologic. The total protein, it should be between 15 to 45. Bacteria, from so gram stain culture should be negative. The acidity is somewhat acidic. It is acidic. The viral DNA or antibodies, it should be none. Lactate dehydrogenase also should be in this value. While in the chloride, it should be about 110 to 125 more than serum chloride. And of course, there is no cancerous cell or the pressure, or what's called the opening pressure. If we take the opening pressure, it should be between 90 to 80. And this is in patient lying in lateral position. If we need to assess the pressure, so it should be in left lateral or lateral decubitus. While in sitting position, we will gain a high pressure, which is not real because of the sitting position. Now, this is showing the finding in different CNS infections. So in bacterial, it will be turbid or yellowish, and the cells is more than 1,000, and mostly are polymorph neutrophils, of course. The protein will be high, and the glucose will be low. In viral, as you see here, it will be lymphocytes, and TB, and in fungal. These findings is important to keep it in examination and in practical life, because according to the finding, we make diagnosis, this is bacterial, this is viral, or sometimes we have mixed cellularity, and we have polymorph and lymphocyte, and this can be seen in cases of partially treated meningitis. I mean bacterial meningitis. Now we are talking about an instrument used in neonatology, used in emergency, and used even in medicine, in internal medicine, which is of course in surgery, widely used, which is the nasogastric tube. We have different sizes and shapes for the nasogastric tube. So this is the adult size, and this is the neonate size. Nasogastric tube, we should use it starting from the neonatal resuscitation, sometimes to make a decompression or removal of the or making a gastric washout or patient that take a lot of amount of the amniotic fluid. لسهول الناس بالعربي شرب مياه راس. The indications of the NG tube. Of course, drainage of gastric content. سهولة decompression. زين. بدنا نطلع الgastric contents. Decompression of the stomach. زين. حتى ممكن air comes through the NG tube. Obtaining a specimen of the gastric contents. Bad. Collection of gastric lavage for AFB. In diagnosis or in doing the AFB, we didn't wait the patient to cough spontaneously and give sputum. The correct way is by introducing NG tube and make gastric lavage. Because of the sputum or the hemoptysis, it will be swallowed and goes inside the stomach. And this should be done early morning before the patient taking or before patient doing a breakfast. So this is the proper way to gain the specimen for the AFB test. Introducing a passage into the GI tract. Allow you to treat the gastric immobility and bowel obstruction. You pass to the GI tract through the NG tube. Drainage and or lavage and a drug overdose or poisoning. This is one of a form of decontamination. Decontamination, which is a principle, a part of management of poisoning, intoxications, whether it is due to poisonous material or drug overdose. Gastric lavage is very important, especially immediately after taking the poisonous material or drug overdose. In trauma, patient has a trauma, and we need to avoid the vomiting and aspiration, putting the NG tube. Assessment of GI bleeding. Patient has GI bleeding, and we need to get the real assessment of the amount. So putting the NG tube is important for that reason. And enteral feeding. Of course, this is part of our field, especially neonatology, for preterm babies and for those with respiratory distress. And we can't start direct feeding because there is difficulties either in sucking or in swallowing, or because the respiratory distress, and we should start feeding. So we start the enteral feeding by introducing the NG tube, or sometimes we call it the OG tube through the oral cavity, through the mouth. And we start giving the trophic feeding through the NG tube and increase the amount gradually according to the response of the patient, before the patient become ready to take direct feeding. So this is in neonatology, which is daily happen in the NICU. Most of the patient starting the NG tube before going to direct tube, up to 99% of them. Then, it of course, can be used in unconscious patients or in cases of dysphagia, malignancy, or bulbar palsy. The same principle, the patient cannot swallow, so enteral feeding comes through this instrument. Contraindications. Not all patients can be used. We have absolute and we have relative contraindications. So, in severe mid-phase trauma, what's called the cribriform plate of ethmoid bone could be disrupted. وين تروح NG tube goes inside the intracranially if there is severe mid-phase trauma. So avoid it. حطوا هنا OG tube, not NG tube. Relative contraindication, when there is coagulation abnormalities or esophageal varices, patient with chronic liver disease, liver cirrhosis, we may induce bleeding by inserting the NG tube. Or if there is esophageal structure or alkaline ingestion. Congenital birth defect, like a cleft lip, cleft palate, also making its or affecting the gastrointestinal tract. So this is making it difficult to do the to do the NG tube. Complications. After putting the NG tube, we may face complication, minor or major. Nose bleeding, sinusitis, sore throat, this can be happened, but the significant is erosion of the nose, esophageal perforation. Of course, these are errors. It should not happen. Or damage to the surgical anastomosis. Patient مسوي له surgical anastomosis ونجح نعطي له NG tube نسوي له. Pulmonary aspiration. Because during inserting the NG tube, we may induce the gag reflex. والgag reflex راح يسوي لنا irritation of the diaphragm. ويصير vomiting, ويصير pulmonary aspiration. Lung collapse also it may happen. And intracranial placement of tube if there is a problem in the mid-phase trauma or the cribriform plate of the ethmoid bone. How to be sure we reach to the proper site of insertion. شلون نقدر نحسبها؟ Like in this picture. Measure the distance from tip of the nose to the earlobe, then to the xiphoid process of the sternum. So to this point, the NG tube, the NG tube should be inserted. These are the landmarks. يعني ما نخليها شغلة subjective. لا، نحدد the length that should be inside by these anatomical landmarks. هاي مرة ثانية تراوينا. يسموا لها نيمو, nose, ear. هذا bottom of breastbone or يسموه له xiphoid process, so reaching to the abdomen safely. So finally, we have, of course, this is syringe of insulin. أكيد شايفيها. What are the indication of using thank you. What are the indication of using syringe insulin? خلينا نسمع من عندكم.
ثيرابيوتيك.
What's insulin, دكتور؟
هاي سهلة. زين. سهلة هذه. Of course, giving insulin. اسمها insulin syringe. خلص نسكت وراها بعد؟
It's used for all doses.
نعم.
دكتور نستخدمها هي بسمول دوز يعني لازم نعطيها.
Very good. Small doses of a drug. Like what? Like what? You have example for this?
Epinephrine, heparin.
Heparin.
Luminal or phenobarbital, digoxin, gentamicin, epinephrine. All these small doses تنحسب بالunits. And in neonates نريد نعطي مثلا فد steroid كلها تنحسب بالunits. For small doses of medication given by syringe of insulin. بعد ايش عندنا؟ شو نسوي؟
For skin test دكتور همنا.
Skin test for what?
for allergy to antibiotic.
Allergy to antibiotic or the hypersensitivity to antibiotic, especially the penicillin, using skin test and so by using the insulin syringe. Bad indications of use. Vaccination like MMR, very good. Given شنو هذا يروح وين؟ intradermal, intramuscular، وين يروح؟ subcutaneous, very good. بعد
دكتور هرمونال يوز هم يعني عندنا الديسندنت تيستس هم ننطي هرمون.
يعني لا. بعد فالindication commonly used diagnostic tuberculin skin test or purify the protein derivatives also by using insulin syringe. فمن اسمها انسولين مو معناتها بس انسولين. It has multiple uses. يعني تشوفوها small, it is of 1 ml, لكن هاي ال 1 ml divided into 100 units. فأي شيء نحسبه بالunits we use the insulin syringe. لكن اسمها insulin syringe لأنه هو ال daily use of it is for DM patients giving the insulin therapy through it. Now we finish the session. أحد عنده سؤال؟ أكو شيء ما واضح؟